Today we'll be talking about thyroid artery embolization. So, talking about thyroid artery embolization, when we talk about thyroid diseases, the patient usually they present with are either in a state of euthyroid, hyperthyroid, or hypothyroid. So, when we talk about thyroid disease itself, so these are my topic discussion outlines: introduction, technique, anatomy, protocol, result, and some cases. So hypothyroid, usually it's either due to iron deficiency or maybe due to Hashimoto's thyroiditis. And some patients are in euthyroid state with normal thyroid function, and some patients may present with high T3, T4 levels in hyperthyroid state. So, and most of the patients who present to us with for seeking treatment for the thyroid-related symptoms, and they are usually having multinodular goiter. And as we know that in case of multinodular goiter, there is only 5% risk of malignancy. So most of the cases, they are actually there is no any need for treatment unless the patient has symptoms related to compression like dysphagia or dyspnea or cosmetic problem. And the treatment options, rightly, like we all know, as it has been always so that the first choice is always surgery, either be it hemithyroidectomy or thyroidectomy. And when we talk about the surgery, it has its own pros and cons, and it has high complication rate. So what are the complications related to surgery? We know that the patient undergoing thyroidectomy, be it total or hemithyroidectomy, may present with transient hypocalcemia, may be present with recurrent laryngeal palsy, hematoma, or seroma. And the second treatment of choice or option for the thyroid patient is ablation, like my colleague discussed previously. It's a minimally invasive procedure if it's effective and safe, less hospital stay. However, there are some challenges concerned with the microwave ablation or radiofrequency ablation itself. So what are the challenges is that if the nodule size is too large with the volume exceeding 20 ml, the treatment may not be possible in a single setting. Also, if the patient has retroexternal extension of the thyroid tissue, the radiofrequency ablation or microwave ablation or as a surgery itself can be challenging because the patient may require sternotomy also. So in such cases, in such instances, thyroid artery embolization may be a viable option for the patient. So when you talk about the TAE, the origin of TAE itself, it was first reported in China in 1992, and it was for the management of diffuse toxic goiter in case of animals. However, in 1994, there was first case report. It was for functional endovascular thyroidectomy, where all the 4 thyroid arteries were embolized, and it was reported in 1994. And after the initial days, the TAE, it became very much popular among general population, and mostly it was used for treatment of Graves' disease actually. So this is one such article. We can see 2 articles actually. In both the cases, there was success rate in reducing the thyroid hormones. However, what we noticed was that besides the patient becoming euthyroid, there was also significant reduction in the size of the volume of the thyroid gland itself. So there was cosmetic treatment also, besides the normal function restoration of the patient. And it was noticed that it was around 30 to 50% at 6 months follow-up. So initially, most of the TAE, it was done for the Graves' diseases. There are many articles we can find in the literature. And so what our technique is, what we did when I was doing my fellowship in Delhi in Sir Gangaram Hospital was that we generally used the common femoral artery route, retrograde access, and we generally used word catheter because it helps us to access difficult tortuous anatomy in case of vertebral arteries or in common carotid arteries or internal external carotid artery itself. And catheter system, we generally used 1.98 micro French Assai or 2.4 French prograde. And for the embolic material itself, we used PBA particles. So talking about the vascular anatomy of the thyroid, we know that the thyroid has a very complex vascular anatomy. there are 4 sets of arteries, superior inferior thyroid artery on either side. Superior thyroid artery is first branch of external carotid artery, and inferior thyroid artery arises from the as a third branch from the thyrocervical trunk, which arises from the proximal part of the subclavian artery. So coming to the particles itself, what particles did we use was that in case of, there were actually 2 choices. We used 350 to 500 micrometer in case of superior thyroid artery, and 200 to 300 micrometer in case of inferior thyroid artery. Why? Because as we know that within the thyroid bed, there are strong collateral communications with other branches of ECA itself and also with the ICA, so that we don't inadvertently embolize other organs. Because we know that same superior and inferior thyroid artery supplies multiple muscles of the neck, larynx, esophagus, also the laryngeal knobs. And other was 200 to 300 micrometer in case of superior thyroid artery, and 350 to 500 micrometer in case of inferior thyroid artery. The cause being the same, to prevent parathyroid non-target embolization and also to prevent extensive necrosis. Because we, on one hand, we want to treat the patient. However, in the other hand, we do not want to render the patient hypothyroid. So the size of the particles from the previous studies, the cadaveric studies, it was found that the average diameter of the capillary network within the body of the thyroid itself, their calibers were generally 0.12 to 0.25 millimeters, with the smallest one ranging from 0.04 to 0.11 millimeter. So what we did was we embolized either 1 or 2 arteries, depending upon where how many nodules were there and on which side the nodules were present. And the endpoint of the embolization was pruning of the vessel with stagnation of flow in 6 consecutive cycles. And we used cone beam CT to confirm our positioning of the catheter system, so that we do not embolize other organs, or also to prevent collateral vessels embolization. And post-procedure, we used IV dexamethasone, also beta blocker, to reduce the symptoms of hypothyroidism. Because what we noticed was after embolizing of the patient, usually due to necrosis of the tissue, the stored hormones, they get released into the circulation, and the patient, there is mostly there, we find that there is a state of hypothyroidism. So any symptoms, if the patient presents with symptoms related to hyperthyroidism itself, so to prevent that as a preventive measure, we usually used beta blocker and antithyroid medications. And IV antibiotics was used for 1 day, and symptomatic management was done depending upon what the patient presented with, if the patient had any post-embolization syndrome or not. And on discharge, oral dexamethasone was used. It was given for 2 days, 4 mg OD, and after that 2 mg OD for 2 days. Beta blockers and antithyroid medications were prescribed for 1 week, and for follow-up, CT scan was done at 3 months and 6 months, and clinical follow-up of the thyroid hormones T3, T4, and TSH was done at 1 week, 1 month, 3 months, 6 months, 12, 18, and 24 months. So what the literature says is that one such article if we read is that one done by Saim Ilmaz, and it is one of the large volume study which we find in the literature itself for the treatment of nodular goiter. And what we see in the study is that significant volume reduction of around 69% was achieved in large single or dominant nodules at 6 months, and which was comparative with the ablation itself. We can see here thyroid volume reduction in 32 group B patients. Group B patients were those patients where the volume reduction of the lobe as counted, whereas in group A patient, generally a single dominant nodule was counted. If you see before and after treatment, significant reduction in both the volumes, pre-treatment and after treatment, and also the thyroid scores, goiter scores, all the scores, significant improvement of all the scores with significant p-value. So comparing the outcomes of various embolic agents that were used previously in what we found in the literature, some used PVA, like Ilmaz et al. Article which was published in 2021. They used PVA along with papaverine. And Kaminsky used histoacryl plus lipidol and PBA also. And Brodowski, they used histoacryl plus lipidol. And Zhao et al. Used PBA and papaverine. In almost all the cases, we find that significant reduction in the volume of the nodules, dominant nodules, and also in the size of the thyroid itself. And major complications, only two such major complications was reported by Ilmaz et al. And that two of hoarseness, and it resolved in 4 days with steroids. So one such study, like most of the studies which were done earlier, most of the clinical trials which were done earlier, most of the procedures, they were done with the transfemoral route from the common femoral route. However, one such study which was published in 2023 and by Kai Lung Chung et al., they described treatment of large sweltering symptomatic benign thyroid nodules through transradial approach, and they also found similar results to what they were previously with the transfemoral route. So what they did was they used microsphere injections. Embospheres, microspheres were used of size 300 to 500 micrometer or 500 to 700 micrometer, and it was mixed with iodinated contrast media with in the 1:1 ratio, and it was gently injected with a 3 ml syringe by pulsing motion in free flow fashion until stagnation. And besides using the embospheres, they also used the pushable coils at the end of the TAE procedures. So in our experience, what we did during my stay in Delhi, we had 6 patients, and 5 were female, 1 was male, and age, they were of age group 29 to 75 with average age of 47 years. Solitary nodule was in 1 and multiple nodules in 5. Single lobe embolization was done in 2 patients, whereas both lobes embolization was done in 4 patients. And in 2 such patients, they were receiving levothyroxine prior to the embolization procedure. And number of arteries embolized, 1 in case of 1 patient and 2 to 3 in case of 5 patients. So what total arteries embolized at the end was 12, and in 6 average follow-up was 6 months, and technical success was seen in 100%. And regarding the complication, transient subclinical hyperthyroidism was seen in 1 patient, and it resolved after 2 days. Sorry. And transient memory loss was seen in 1 patient, and it also resolved after 5 days, and no mortality was there. So considering the outcomes, volume reduction, we can see pre and post treatment significant volume reduction. Also the intrathoracic extension also reduced, and Goethe score, visual analog score, and cosmetic risk score, they all got better post procedure. So talking about the case, there was 1 patient with 66-year-old female with neck swelling for 5 years. And FNAC, with STA2, THYROID2, and TFT was normal. This was pre-procedure. So this is the ultrasound of the patient. We can see on the left-hand side, this is of the left lobe. There are few nodules, smaller nodules with relatively normal volume of the thyroid size of the left lobe. However, on the right side, multiple nodules with large volume of the right lobe of thyroid. We can see 346 ml prior to embolization. So on this side, we can see this is of the patient. The catheter is positioned here within the brachycephalic trunk. Here we can see this is the injection of contrast media into the inferior thyroid artery, and we can see there is the blast of the nodule, including the left of the lobe. And we can see the downward image, we can see that there is a catheterization of the superior thyroid artery, and there is blast of the nodule itself. This is the pre-procedure, and this is post-procedure of the inferior thyroid artery. We can see the blast which was seen previously, it's not there. Also, when we see of the, sorry. Also, we can, when we see of the superior thyroid artery, there is no any blast there. So this was prior to the embolization. and this was at 6 months follow-up. You can see visually also there is marked reduction in the cosmetic appearance of the patient. And the patient, 39-year-old female with neck swelling, which was there for 10 years, and now she presented with mild pain. This was prior to the embolization, and this was the ultrasound image of the patient. We can see the thyroid volume is 235 ml. And this is the coronal CT scan of the patient, lung window. We can see large right-sided thyroid nodule with retroesternal extension, and there is compressive symptom over the trachea also. We can see here, this is of the inferior thyroid artery. There is large tumoral bulge on the right side. This is prior to the embolization. This is of the superior thyroid artery. We can see the bulge. This is post-procedure. We can see both the inferior and superior thyroid artery. The bulge which we saw previously prior to the embolization, there is no bulge right now. So this was prior to the embolization. This was at 1 month follow-up, and this was at 6 months follow-up. We can see visually also there is marked reduction in the size of the swelling also, and also while ultrasound, when we did the ultrasound, there was marked reduction in the size, volume of the thyroid gland itself. So concluding my talk here, what we can say is that when the nodule is limited within the neck itself, microwave may be a more viable option compared to TAE. However, in case of retroesternal extension of the thyroid nodule, or when the thyroid volume is large, where a single setting microwave ablation or thyroid radiofrequency ablation may not be a viable option, thyroid artery embolization may be a better choice. Also, in case of hypertrophic arteries, even when the nodule is limited within the neck itself, microwave ablation may also be a potential alternative to, TAE may be a potential alternative to microwave ablation. However, the choice of treatment, it depends upon the operator. However, what we know until now is that TAE, in case of retroesternal extension or large thyroid nodules, it may be a more viable option. However, more studies needed to determine as such how to say who may be the ideal candidates for the TAE, what may be the ideal size of the particles, are there any role of liquid embolics for the thyroid artery embolization, and also we do not know the long-term follow-up in case of patients with TAE. Also, the sample size for such procedures are not there in the literature, and also there is no any comparative study concerning the surgery versus the TAE to say whether the surgery is a more viable option or TAE is a more viable option for the patient with retroesternal goiter or large thyroid nodules. Thank you.